Thank you, sir. Thank you so much. So, hi, good morning, everyone. So, let me introduce myself. My name is Vibha Ratheesh. I have been working as a IPDRG medical coder for past 5 years. And before stepping into this role, I had a privilege of working as a medical coding trainer also for 1.5 years. At present, I am employed with uh, Claims Care RCM, and I truly enjoy being part of this organization. So it is my pleasure to connect with you all, and I look forward to learning, collaborating, and growing together. Okay, so let us begin our session. So today we will be having a session regarding the ICD and CPT coding guidelines that related to spine, the coding challenges that we face during the spine coding the spinal surgeries, and the strategies for managing the insurance denials. So before diving into the session, I would like to give you an overview about the anatomy of the spine, the coding, the conditions that affecting the spinal cord, and the procedures that performed on it. So this will give you a clear picture about the spine as a whole. Okay, so uh, first of all, let me start with CNS. So what is CNS? Basically, the nervous system of the human body is classified into two, CNS and PNS. That means central nervous system and the peripheral nervous system. Central nervous system is responsible for controlling the voluntary and involuntary actions of the body. That means the voluntary actions like walking, speaking, etc., and involuntary actions like breathing or respiration, digestion, reflex actions, etc. So, this CNS or central nervous system is responsible for controlling the voluntary and involuntary actions of the body, whereas the PNS or peripheral nervous system connects this central nervous system to other body parts, I mean limbs or other parts of the body. This central nervous system comprises the most important part of our body, the brain and the spinal cord. The brain act as a primary control center, whereas the spinal cord act as a communication highway or pathway between the brain and rest of the body. That means this spinal cord receives signals or sensory inputs from the from rest of the body, and it give partially process it, and it give to brain. Likewise, the brain transmit these signals through the spinal cord to other parts of the body, like the CPU in a computer. This brain and spinal cord act as a CPU in a computer. That means hence this central nervous system is considered as the command center of the body. Okay, this spinal cord, this I already told, this nervous system consists of the brain and the spinal cord. So this spinal cord, it is a very thin, delicate structure that is made up of nervous tissue. This is protected by or enclosed in a column like structure called spinal column. So next we are going to see what is spinal column and its structure in detail. Okay, so what is a spinal column? Spinal column is, see this picture. What is a spinal column? Spinal column, it is a flexible structure that is made up of 33 number of small irregular bones called vertebrae. These vertebrae are separated by a disc-like structure called intervertebral disc. So this is a spinal column. So the spinal column begins from the lower part of the brain, that means brainstem, and extend up to the pelvic region. Okay, so thus it provides a structural stability to the human body, a structural stability to the upper part of the human body. So hence it is known as, this spinal column is known as the central pillar of the body or backbone of the body. Okay, this so as I already told, this is made up of 33 number of small irregular bones called vertebrae. Since they are made up of vertebrae, they are also known as vertebral column or spine. Okay, this is about the spinal column. So our spinal cord is protected by or enclosed in a structure called a spinal column or vertebral column or spine. These vertebrae, or these bones are arranged sequentially, one above the other. Okay, one above the other, and it forms a column-like structure. Next, we are going to see the structure of the spine. So, this spinal column is divided into 5 segments. What are the 5 segments? Cervical spine, thoracic spine, lumbar spine, sacral and coccygeal spine. So, what is cervical spine? Cervical spine is the upper part of the vertebral column, or it is the first part of the vertebral column. This cervical spine consists of 7 vertebrae. It is made up of 7 vertebrae. C1 to C7. These vertebrae are labeled or named as with numbers. Means cervical. The C1 C stands for cervical region. So C1, C2, C3, like up to C7. So this cervical spine is made up of 7 vertebrae. These vertebrae are separated by a disc cartilaginous plate or a disc-like structure called intervertebral disc. Okay. The main function of the cervical vertebrae is to keep the head upright. So this C1 vertebrae and C2 vertebrae. See this picture. This C1 vertebrae and C2 vertebrae has some special name. C1 is also known as atlas. C2 is also known as axis. This main function of this atlas or C1 vertebrae is to keep the head upright and allow the movement of the head. Whereas, what is the function of C2 or axis? C2 act as a pivot for C1. That means it helps in side-to-side rotation of the C1 vertebrae. Okay. So, about the cervical spine, it is made up of 7 vertebrae, C1 to C7. It is separated by intervertebral disc. The main function, it is the upper part of the the first segment of the cervical spine, vertebral column, and this main function of this cervical vertebrae or spine is to keep the head, or it provide the support to the head. Okay, then comes thoracic spine, the middle segment of the vertebral column, or the second segment of the vertebral column, that is thoracic spine. This thoracic spine is made up of 12 vertebrae, which are separated by intervertebral disc. 12 vertebrae, T1 to T12, T1, T2 up to T12. Since it is made up of 12 vertebrae, it is the longest segment of the vertebral column. Okay. These thoracic vertebrae, the main characteristic of this thoracic vertebrae is this is the attachment point for the rib bones. That means, see in this picture, this is these green colored vertebrae. These are thoracic vertebrae. This T1 vertebrae attached to the each pair of rib bones at both sides. See, T2 vertebrae attaches to the next pair of rib bones like T12. Till T12, they attaches to these each pair of rib bones and form a thoracic cage. This thoracic cage helps in protecting the thoracic organs like heart, lungs, etc. Okay, so this is the main characteristic feature of thoracic spine. So the second segment of the thoracic spine is the second segment of the vertebral column. It is made up of 12 vertebrae which are separated by intervertebral disc. Then this thorax, since it is made up of 12 vertebrae, it is the longest one, longest among the other spine. Okay, then this thoracic vertebrae act as an attachment point for the rib bones and it forms a cage, and this helps in protecting the thoracic organs like heart, lungs, etc. Okay, then comes the lumbar spine. So lumbar spine is made up of 5 vertebrae, L1 to L5. This is the most rigid vertebrae because it helps in lifting, bending, etc., allowing the movement, and it also provides a structural stability to the upper part of the body. So these vertebrates are large vertebrates when compared to other vertebrates. These lumbar vertebrates are large blocks when compared to other vertebrates, and the main function of this lumbar spine or lumbar vertebrae is to provide the structural stability, and it also helps in weight bearing. Okay, so this is about the lumbar spine. Next comes the sacral and coccygeal spine. This sacrum and coccyx spine, it is considered as the false vertebrae, or it is this sacrum is a uh, what it is made up of 5 fused bonds. This sacrum region. So the sacrum and coccyx, there is no intervertebral disc in between this sacrum and coccyx. So this is considered as the what false vertebrae because they fuse together at the age of 18 to 30. These sacrum and coccyx vertebrates typically they fuse together at the age of 18 to 30 and finishing in the middle age. Okay, so this is about the uh, what the segments: cervical spine, thoracic spine, lumbar spine, sacrum, and coccyx. This sacrum spine, no, this sacrum spine, the sacral vertebrae linked with the iliac and forms a sacro-iliac joint. Iliac bond to form a sacro-iliac joint, and it also helps in this providing the structural stability to the human body. Okay. So this is about the cervical, thoracic, lumbar, sacral, and coccygeal spine. The other supporting structures of the spine are intervertebral disc, facet joints, spinal ligaments, spinal muscles, and tendons. So before going into the details, I would like to give you a note on vertebrae. So we already discussed that this spine, it is made up of small irregular bonds called vertebrae. So this What makes up each vertebrae? That we are going to see next. So before seeing the intervertebral disc and all, so this vertebrae, as I already told, it is made up of, it is a bone, small irregular bone. So while this is the structure of a vertebrae, when we took a vertebrae, this is the superior view or top view of the vertebrae. This is the lateral view of the vertebrae. That means, suppose this is the L1 vertebrae, this is the L2 vertebrae. In between the vertebrae, there is a disc. So this is considered as the vertebral body. This is the lateral view. Here in the top view or superior view, this is that portion. Here the disc, we can see the disc. This in between this vertebral body, we can see the disc. So this is the vertebral body, and above the vertebral body, the disc is placed. Okay. So this is the anterior portion. This down, it is the posterior portion. Okay, posterior side of the vertebrae. So this vertebrae has, so in its anterior side, there is vertebral body, and above the vertebral body, there is a disc. So this is the anterior side. And in the posterior side, it has three projections. Side lateral projections are the side to side projections, and the middle projection is there. This middle projection is known as spinous process, and the side projections are known as transverse process. And in between these process, there is lamina, a bony structure. The structure in that bone is called lamina. Okay. Then we have a central space here. This is called foramen. This is known as foramen. Okay. So when we arrange these vertebrates one above the other, these foramen, no, these space, it form like from the cervical region till the lumbar region. When we arrange these vertebrates in sequentially in one above the other, there forms a canal-like structure. This space form a canal-like structure that is called spinal canal. Okay, within this spinal canal, our spinal cord runs. Okay, extend. So this is about the structure of the vertebrae, and also in the middle we have another space that also we call it as foramen. Through this yellow colored structure is called spinal nerve. These nerves exit through these foramens. Okay, so this is the superior view of a vertebrae, and this is the lateral view of the vertebrae. So I hope you understand what is vertebrae and what is its structure. Okay, this is the side view and this is the top view. So keep in mind this while we coding the spinal surgeries or spinal conditions, especially the spinal surgeries procedures, we have to know thoroughly about the structure of the spine, the vertebrates and all. Okay. So this is what. So each vertebrae, I mean cervical vertebrae, thoracic vertebrae, and lumbar vertebrae is different. Is different as its own. It has its own characteristic features. Okay. So I already told there is a lateral projection and central projection, that is a spinous process and transverse processes that act as an attachment point for the muscles also. Okay. Then we move on to the structural, other structural support that given to spine. What are the structures that give that helps in supporting the spine? The first one is intervertebral disc. What is intervertebral disc? These cervical vertebrae, thoracic vertebrae, lumbar vertebrae, all are separated by intervertebral disc. So this is actually a cartilaginous plate. It provides a cushioning effect to the vertebrae. Okay, so from C3 to L5 only we can see this intervertebral disc. So it acts as a shock absorbers. That means it helps in preventing the vertebrae from rubbing against each other. So any damage to this disc or like herniation or degeneration or prolapsed disc, this will cause this will harmly affect the vertebrae and which will leads to intervertebral disc disorders. Okay, so this main function of this intervertebral disc is to provide the what to provide a cushioning effect to the vertebrae, and it act as a shock absorbers, and it prevent the vertebrae from rubbing against each other. When we see the structure of the disc, it has two parts. The outer ring, it is called annulus pulposus fibrosus, and the center gel-like material, it is called nucleus pulposus. This is the two main parts of the intervertebral disc. Okay. Next, other supporting structures are spinal ligaments, facet joints, spinal muscles and tendons, and curves. So, what is spinal ligaments? What is ligaments? Ligaments means it is a tough band of connective tissue that in connects two bonds, or we can see these ligaments in the joints also. Okay, so it connects two bonds. It provides structural stability to the joint. Like same function here also. Spinal ligaments. It is a tough band that stabilizes the spine during the movement. Any instability to ligaments leads to degenerative disc disease and nerve compression at facet joint. Okay, so spinal ligaments are tough band of connective tissue that we can see in between the two bonds. Not in between, that connects two bonds. Okay, here we can see some spinal ligaments that are interspinous ligament, supraspinatus ligament, like. Okay, next one, facet joint. What is the function of this facet joint? Facet joints are paired joints located on the back of each vertebrae that allow controlled spinal motion. Okay, sometimes during spinal surgery, these facet joints can cause what any this nerve compression. Any sometimes the patient may admitted with nerve compression and intervertebral disc disorder, and the physician may sometimes perform the facet joint injection to relieve the pain. So that is the importance of this facet joint. It is a pair of joints that are located on the back of each vertebrae that allow controlled spinal motion. So any damage or any that conditions that affecting the facet joint may uh, may cause a may have a impact may have a what impact this they affect the spinal motion and also cause nerve compression. Okay, then comes to spinal muscles and tendons. So this helps in providing the strength, maintain posture and control movement. Then comes curves. What is curve? This spinal, the human spine normally have curves. Curves means this upward. See this is the human spine, and this have inward curve and upward curve. Okay, inward curve and upward curve. These curves helps in the curves helps in the balance. Any this inward curve, the cervical region has an inward curve. This is called lordosis, and this thoracic region has a outward curve, that is kyphosis. We call it as kyphosis. Again, this lumbar region has an inward curve, that is lumbar lordosis, and sacral region as outward curve, that is sacral kyphosis. So these curves, cervical and lumbar lordosis, thoracic and sacral kyphosis, helps in the balance and flexibility of the spinal column. Okay, so any hyperlordosis or any loss of lordosis or any hyper what kyphosis will will have a drastic impact on the spine. So it will require spinal correction. Okay, so this is about the supporting structures of the spine. So this spinal column is made up of, divided into 5 segments: cervical, thoracic, lumbar, sacral, and coccyx. So, and the other supporting structures of the spine are intervertebral disc, facet joints, spinal ligaments, spinal muscles and tendons, and also spinal curves. Okay, then comes the spinal cord. So we already discussed about the spinal cord. That is, the spinal cord, it is a long, thin, delicate structure that is made up of nervous tissue that is protected by or enclosed in a spinal column or vertebral column. And it acts as a communication pathway between the brain and the rest of the body. So this spinal cord, it extends from the medulla oblongata in the lower brainstem to the lumbar region. Till L1, L2 only, this spinal cord runs. Okay, this spinal cord plays a crucial role in facilitating our daily activities. The main function is it carries nerve signals from the brain to the other parts of the body and commanding the muscles. And also it receives the sensory input from the body, partially process it and transmit the information to the brain. Okay, so see the spinal cord. So it is a long, thin cylindrical structure that is made up of nervous tissue, and it begins from the lower part of the brain till this green colored L1. See this L1 vertebrae now. Till this spinal cord runs through the vertebral column till L1 vertebrae. Okay, so it is approximately 42 to 45 centimeter length and 1 to 1.5 centimeter diameter. So it has a bilateral symmetry, and the main function of this central the spinal cord ends in L1 to L2 vertebrae, and the end point is known as conus medullaris. After that, we have chorda equina and then phylum terminale. This portion is known as phylum terminale, which acts as an anchor for spinal cord, which acts as an anchor. It attaches the spinal cord to the coccyx region. Okay, so this is the structure of this spinal cord. And this spinal cord is protected by a 3-layered protective membrane called meninges. It is protected by, the spinal cord is protected externally by some structures called vertebrae, meninges, nerves, etc. And this meninges, what is meninges? The spinal cord is protected by a 3-layered outer covering called meninges. This, what is meninges? Then we are going to see about the spinal meninges. So the spinal meninges is a 3-membranous structure. The outside structure is known as, this orange color, this outside structure is known as dura mater. The inside, the middle structure is known as blue colored, this one is known as arachnoid matter, and the inner structure is known as pia matter. So spinal meninges are three it is a protective uh, covering of spinal cord that is made up of three layers. The outer layer is known as dura mater, the middle layer is known as arachnoid matter, and the inner layer is known as pia mater. Okay, so what is dura mater? Dura mater is the outermost layer. It extends from the foramen magnum. Where is foramen magnum? This vertebrae has some space. It is called foramen magnum. To the phylum terminale. What is the phylum terminale? As I already told, this this central portion, this cream colored portion is a spinal cord, and it ends in a conus medullaris and caudicina, and this is this terminal, and it is known as what? Phylum terminale. Okay, so this dura mater extends from the foramen magnum to the phylum terminale, and it is separated from the wall of vertebral canal by epidural space. So, where is this epidural space? Epidural space, it is in between the vertebral canal and the dura mater. So, actually, this is a spinal cord, and this is the meninges. The spinal cord is protected by a three-layered structure called meninges, and these meninges or this spinal cord, it is located in the vertebral column. So the space between the vertebral column and the first part of the first part of the meninges, that is dura mater. That space is known as epidural space. Okay. Next comes arachnoid matter. So arachnoid matter is the second layer of the meninges. Arachnoid matter is the second layer of the meninges or middle layer of the meninges. It is a delicate membrane that is located between the dura mater and the pia mater. Pia mater is the innermost layer. Okay, so this it is separated from the pia mater by a space called subarachnoid space. That means this arachnoid matter, in between this arachnoid matter and the innermost layer pia mater, there is a space called arachnoid space. Okay. Next comes the pia mater. So pia mater is the innermost of the meninges. It is a thin membrane that covers the spinal cord, nerve roots, and their blood vessel. Because this innermost layer, it is the innermost layer and it covers the spinal cord. Okay, this is about the spinal meninges. So spinal cord, it is a thin, delicate structure that is made up of nervous tissue that extends from the medulla oblongata of our brain till lumbar region. I mean L1 to L2 region, and this is protected by a three-layered membrane covering called what? Meninges. These three layers are: outermost layer is called dura mater, and the middle layer is called arachnoid mater, and the innermost layer is called pia mater. The space between the dura mater and the spinal column is known as epidural space. Space between the subarachnoid matter and the pia mater is known as what? Subarachnoid space. Okay, and the terminal end, this is conus medullaris. The spinal cord ends in a here. Spinal cord ends in a L1, L2 space, and here It is known as conus medullaris. It is a clinically important structure of the spinal cord. It helps in the bladder function, bowel function, and also sexual function. Okay, it is the terminal tapered end of the spinal cord. Below this conus medullaris, there comes the cauda equina. It is the bundle of nerve roots at the lower end of the spinal cord. Hence, it is also known as horse tail because it is a collection of lumbar, sacral, and coccygeal nerve roots. Okay, so it is considered as a horse tail. Below that, what structure? Phylum terminale. The main function of this phylum terminale is to anchor the spinal cord to the coccyx. Okay, this is about the structure of the spinal cord. I mean, external structure of the spinal cord. And while come to the internal structure, we can see this is the cord, no? This is the spinal cord. While come to the internal structure, we can see the two matters are there. This gray matter and white matter. The outer portion is white matter and the inner butterfly shaped portion is what? Gray matter. So next we are going to see the function of gray matter and white matter. So internally the spinal cord is made up of two matters, gray matter and white matter. Externally it is made up of, means it is protected by a covering called spinal meninges. Okay, understand. So this gray matter, it is a what? In the interior of the spinal cord is formed by gray matter. And the gray matter consists of neuron cell bodies, dendrites, and glial cells. And white matter consists of myelinated axons. This axons gives the white matter a white color. Okay. So what is the function of this gray matter and white matter? Gray matter processes spinal reflexes and act as a relay station for sensory and motor information, while white matter transmits signals from the brain and the body. So white matter transmit the signals between the brain and the body. So this is all about the structure of the spinal cord, spinal column, spinal cord. Okay, and so this CNS consists of what? The central nervous system consists of brain and spinal cord. The spinal cord is enclosed in or protected by spinal column or vertebral column or spine. So this spinal column is divided into 5 segments: cervical, lumbar, thoracic, and sacrum and coccyx. It is made up of 33 number of vertebrae, and this spinal column, these vertebrae sequentially arranged one above the other and form a canal-like structure inside the vertebrae, and it is known as spinal canal. Within the spinal canal, a cord-like structure that extends from the lower part of the brain uh, till the lumbar region. It is known as spinal cord. It is made up of nervous tissue, and it acts as a communication pathway between the brain and the spinal cord. And this spinal cord is protected externally by spinal meninges, which is a 3-layered membrane covering, and dura mater, pia mater, and arachnoid matter. Then internally, it has 2 structures, the white matter and gray matter. This white matter transmits signals between the brain and the body, whereas it is made up of, it consists of myelinated axons. And this gray matter, it processes spinal reflexes and act as a relay station, which is made up of neuron cell bodies, dendrites, and glial cells. This is about the anatomy of the spinal cord and spinal column. Okay, next we move on to the function of the spinal cord. As we have already discussed what is the function of the spinal cord, that it is spinal cord receives sensory inputs from the body. that means touch, that sensory inputs that from the body via nerve roots or spinal nerves, and it relays this information, or it transmit this information to the brain. Okay, and then this process, the second function of the spinal cord is after receiving the signals, it process it. These signals, it process it. The spinal cord serves as a local processing center for reflex arc and segmental coordination. It integrates input from the sensory neurons and interneurons to generate immediate motor output without the brain involvement. So the primary function is to receive, then the received signals, it process it, and then export. The spinal cord sends motor commands to skeletal muscles via ventral roots, nerve roots. It also transmits autonomic output to organ. It carries descending input from the brain and give it to other parts of the body. So receive, process, and export is the main function of the spinal cord. Okay. Next comes this we have already discussed. What are the major parts of the spinal cord? Cervical cord, thoracic cord, lumbar cord, sacral, conus medullaris, caudicina, gray matter, white matter, and central canal. We have already discussed the function. The central cervical cord controls head. It is in the neck, no? This cervical region, it is in the neck. So this is main function of the cervical cord is to control the head, neck, arms, and any compression to the nerve roots are exiting from the cervical region may cause cervicalgia or radiating pains to the upper limbs. Okay, so like this controls head, neck, and arms. And thoracic cord, it helps in chest and abdominal. It innervates the chest and abdominal wall muscles. Lumbar cord controls lower extremity movement. Because from the lumbar region, the spinal nerve roots, nerves, the spinal nerves that exit from the lumbar spine mainly control or mainly helps in the movement of lower limbs. Okay, lower limbs. So any damage to the lumbar region may affect the movement of the upper limb, lower limbs. Okay, it may affect, drastically affect. Next comes sacral. Sacral cord. It innervates pelvic organs, bladder, bowel, and lower limbs. Okay. Then we have already discussed about the conus medullaris. It's a tapered terminal portion of the spinal cord. Then caudicina, it is considered as a host tail. It is also known as the host tail because it is a collection of lumbar, sacral, and coccyx nerves. So, and the gray matter, white matter, and central canal. Okay, then comes spinal nerves. So, what is a spinal nerve? Spinal nerves are spinal nerve roots are bundles of nerve fibers that emerge from the spinal cord and exit the vertebral column through small openings between the adjacent vertebrae. That means this is the vertebrae. We have already seen the structure, no? Here. Here you can see. This is the vertebrae. Okay. Here, this is the vertebral body. Here in the vertebral disc, and the middle portion is here. This is the space, and here the spinal cord. And here in the two sides, lateral sides, we have a space, foramen, through which the spinal nerve exit. Understood? This in between this vertebrae, there is a space through which spinal nerve exit. That is what we have discussed. So Spinal nerves are bundles of nerve fibers that emerge from the spinal cord and exit the vertebral column through small openings between the adjacent vertebrae. There are 31 pairs of nerve roots in the human body. 31 pair. Each set of spinal nerves exit through specific foramina to serve particular areas of the body. That means the spinal nerves that exit from the cervical region um, what will helps in the sensory or motor functions of cervical region or the upper limbs. Okay, like that. Here we can see cervical spinal nerves associated with the breathing, shoulders, parts of the arms, esophagus, and parts of the chest. Whereas thoracic, the spine nerves that exit from the thoracic vertebrae, or I mean thoracic spine, that connects to parts of the arm, esophagus, trachea, heart, lungs, and small intestine. Where the nerves that exit from the lumbar spine primarily control the legs and the feet. And the sacral nerves responsible for bowel, bladder, and sexual functions. Okay, so each pair of nerves has its own functions, and it typically this set of what each set of spinal nerves exit through specific foramina to serve particular areas of the body. So each has its own function. Though there are 31 pair of nerve roots, spinal nerves are there. Okay. And we have two type of nerve roots, sensory nerve roots and motor nerve roots. What is the function of these sensory nerve roots? It contains nerve fibers that transmit information from the body to the spinal cord, such as sensations like touch, pain, temperature, etc. Whereas the motor nerve roots contain nerve fibers that transmit information from the spinal cord to various muscles, controlling the voluntary movement. Okay, so in brief, the spinal nerves there are 31 pair of spinal nerves are there, and its a function specifically depends upon the region, I mean from which they exit. So cervical spine affects upper part, upper limbs, then thoracic spine that connects to esophagus, trachea, heart, thoracic organs, and lumbar spine primarily it controls the lower limbs, and sacral nerves it helps in what bowel, bladder, and sexual functions. Then sensory nerve, and what is the difference between sensory nerve and motor nerve? Sensory nerve which helps in sensation of touch, pain, temperature, etc. Whereas the motor nerve nerve root contains fibers that transmit information to control the voluntary movement. Okay. And each pair of nerve root, each pair of nerve root, see, from this nerve root exit, each pair of nerve root is associated with a dermatome. What is dermatome? It is an area of the skin that is supplied with sensory fibers from a single spinal nerve root. Okay, so each pair of nerve root is associated with a dermatome. So, any damage or compression of a nerve root can cause pain, weakness, numbness, or tingling in the area of the body supplied by that nerve root. That means if cervical region, the spinal nerve root, if a patient what this is spinal nerve root in the cervical region is affected, then it will cause radiating pains to what cervical means upper limbs. So the damage or compression of a nerve root that can cause pain, weakness, numbness, or tingling in the area of the body supplied by the nerve root. Nerve root compression is a common cause of conditions such as herniated disc, spinal stenosis, sciatica, etc. Because this herniated disc and spinal stenosis, which means narrowing of spinal canal, which will cause the nerve root to compress. Okay, so for that we have to done decompression of spinal nerve root. It is performed by neurosurgeon. Okay. The treatment for nerve root compression may include medication, physical therapy, spinal steroid injection. Uh, that means spinal steroid injection means this epidural injection, then facet injection, that all we will perform for this nerve root compression, and in severe cases, surgery to relieve pressure on the affected nerve root. Okay, so this is about the spinal nerves. And spinal curves that we already discussed about the spinal curves, that a human normal healthy spine has what lordosis and kyphosis is there. That means the outward curve and inward curve is there. But any hyperkyphosis or any hyperlordosis will have correction, will require what correction. So abnormalities in the spinal curve can lead to various health issues because it will affect the mobility and the overall quality of the life. So these deviations from the normal spine curvature are often categorized as excessive lordosis, excessive kyphosis, or scoliosis. Scoliosis means what? Scoliosis is the lateral curvature. I mean, side curvature of the spine. That is the scoliosis. Lordosis means inward. Kyphosis means outward. Scoliosis means to lateral side, the spine will curve. The lateral side. Okay, that is a scoliosis. So, any excessive lordosis, kyphosis, or scoliosis will require immediate medical attention. Okay, excessive lordosis, also known as hyperlordosis, it is mainly caused by obesity, poor posture, weak abdominal muscles, or congenital spine abnormalities. Whereas excessive kyphosis or hyperkyphosis is commonly seen in the elderly patients. Elderly persons often due to osteoporosis or degenerative disc disease. Okay, what is osteoporosis? Osteoporosis, which means the density of the bone. It will lack the density of the bone. Okay, and degenerative disc disease, which means wear and tear due to age. So excessive kyphosis or hyperkyphosis is commonly seen in the elderly patients, often due to osteoporosis or degenerative disc disease. Then scoliosis is a condition where the spine curves sideways in a S or C shape. It is often diagnosed in childhood or adolescence. So this is a scoliosis. See, this is the normal spine, and this is a this S-shaped or C-shaped lateral curvature. It is known as scoliosis. Okay. So this is about the spinal curves. Okay. So this is about the anatomy of the spinal cord. So this this corders must aware of the anatomy of the spine while doing spinal coding, while coding the spinal surgeries, and while assigning the ICD codes for spinal conditions. Okay, so next we move on to the common conditions that affecting the spinal cord. So for our better understanding, we can categorize this spinal conditions into degenerative condition, inflammatory condition, infective conditions, structural and congenital, and tumors, vascular issues. Okay, so what is degenerative condition? Degenerative conditions are usually they occur that usually due to wear and tear or current due to uh, old age, this degeneration may happen to disc or vertebrae. This will cause degenerative conditions. For example, herniated disc, spinal stenosis, degenerative disc disease or osteoarthritis, spinal muscular atrophy. These all are come under degenerative conditions. This herniated disc, which means we can see the picture here, diagram. This disc bulge out. Herniation. Herniation means this disc bulges out and it will cause compression on nerves, pressing on nerves. That is, these nerves become compressed, and it will cause pain to the uh, patient. Okay, that is herniated disc. Then what is spinal stenosis or spinal canal stenosis? That means the narrowing of the spinal canal. That will compress the spinal cord because the space in the spinal canal, it become narrowed. That will affect the spinal cord, and spinal cord compression may happen. It will compress the spinal cord. Okay, for that also surgical correction required after if physiotherapy and other conservative management not works. Then comes degenerative disc disease or osteoarthritis, that is wear and tear on spinal joints. Okay, next comes inflammatory and autoimmune diseases. So inflammatory diseases like multiple sclerosis. Multiple sclerosis is a autoimmune disease. What is autoimmune disease? Our body recognize our cells or our organs as a foreign, and it will attack. Okay, this is a autoimmune disease. So this multiple sclerosis is a autoimmune disease, and it attack our nerve sheath, and it will destroy them. And this will leads to a big impact on the overall quality of the life of a patient. Then comes transverse myelitis. Myelitis, itis means inflammation. So transverse myelitis means inflammation of the spinal cord. Then comes ankylosing spondylitis. This is the inflammatory arthritis affecting the spinal cord. Next, infections. The meningitis, polio, syphilis, HIV are the common infections that occur to the spinal cord. That means meningitis infection that can directly harm the cord. Sometimes this meningitis can caused by virus or bacteria, and it will cause severe headache, neck stiffness, and all. So that is the condition. Then abscess. Abscess means it is a collection of pus. That means mm, it is contaminated, or it is this collection of pus means that is infected. That is the abscess. Infective conditions, meningitis, polio, syphilis, or HIV. It will directly affect the spinal cord. Then abscess. Then comes structural and congenital. So the conditions that come under structural and congenital include spina bifida, scoliosis or kyphosis, syringomyelia. Spina bifida, it is a birth defect where the spine doesn't close properly. Usually it occur at during the development of a embryo. So for these, intrauterine corrections will perform. Physicians will perform intrauterine surgery to correct the spina bifida. In this condition, the neural tube does not close properly. That is this neural tube develops into brain and spinal cord later, but it does not close properly. That is the spinal bifida condition. Okay, scoliosis and kyphosis we have already discussed. So it is a structural condition, that structural defect that occur to the spinal cord. Then syringomyelia, which is a fluid-filled cyst that forms in the cord. For that, the drainage will perform. Okay, this is the structural and congenital conditions. Then comes tumor. Tumor, of course, that growth within or tumors are growth that may form either within the spinal cord or outside the spinal cord, including metastasis. Okay, then vascular issues, that problems with blood supply to the cord. Okay, so these are the conditions that affecting the spinal cord. Degenerative conditions, inflammatory and autoimmune conditions, infections. Infections mainly caused by organisms, microorganisms, then structural and congenital conditions, then tumors and vascular issues. Okay. Then comes to the coding part. So, ICD coding guidelines for spinal cord conditions. So, what are the so in this session we are going to discuss about the uh, what are the requirements that coders have to take care of some areas while coding what spinal conditions, what are they, what are that this one that we are going to discuss. So code to the highest level of specificity. That means ICD 10 cm requires documenting the exact spinal region. So the coder must check for which spinal region is affected. This is cervical region, either thoracic region, lumbar region, sacral region, which region is affected, or if a patient admitted with cervicalgia, I mean this intervertebral disc disorder on C3, C4, then we have to assign the correct ICD code. We have to select the correct ICD code based on the what anatomical level it affected. Okay, that is the most important one. Then use combination code when available. That means many spinal conditions have combination code. That means intervertebral disc disorder with the radiculopathy. Radiculopathy, which means radiating pains to upper limbs, either upper limbs or lower limbs, whatever it may be, it is a radiating pain. Radiculopathy means a radiating pain. We have a combination code for intervertebral disc disorder with radiculopathy. So we have separate code also. Radiculopathy has separate code also. So coders should assign the combination code if available, not assign the codes separately. It will leads to rejection. Okay. Then follow the official ICD 10 cm guidelines. Uh, that means we have to follow, coders should, must follow the ICD 10 cm guidelines while coding spinal surgery, spinal conditions. Okay, sequence code based on the reason for encounter. So it is the most important when selecting a principal diagnosis is the most challenging and the most important that coders must follow. The primary diagnosis must reflect the chief complaint or condition being treated. So avoid unspecific codes when documentation supports specificity. So always code for codes with specificity. Otherwise, we have to raise query for physician for the specificity. Do not report unspecified spinal region codes, which will also sometimes leads to rejection. Okay. So these all are the criteria that we have to check while we have to be careful while coding spinal conditions. Then key documentation requirements for spinal condition. We have already discussed in brief. Spinal coding requires careful attention to anatomical level. That means which level affected. Then underlying pathology. That means if a patient admitted with pain, radiating pain, if the underlying condition is a stenosis or a disc herniation, this due to this stenosis or a disc herniation, the patient may what patient may have that pain or radiating pain, then the coder should assign the underlying condition, that is the ICD code for stenosis. We have to assign the ICD code for stenosis instead of pain. Okay. Then comes the laterality, unilateral, bilateral, whatever it is, we have to uh, assign the based on the documentation, the laterality. Then episode of care, that is initial, subsequent, sequelae. This mainly these seventh character, initial, subsequent, and sequelae, mainly apply for traumatic injuries only. If a patient had a what accident, RTA, road traffic accident, and if patient admitted for vertebral fracture, then while coding the ICD, we have to assign the seventh character A, initial, depending upon the encounter or visit, or based on the treatment provided. We have to check. Okay, initial, subsequent, sequelae. Then type of injuries, traumatic versus non-traumatic. So we have to check for the documentation, because non-traumatic, suppose, for example, if a patient with the osteoporosis uh, may develop a vertebral fracture, that is due to, that is a pathological fracture actually. Due to this osteoporosis, patient had that fracture. So that is non-traumatic. But if a patient had a accident or a trauma, and this patient developed that vertebral fracture, that is traumatic. So differentiate the injuries, that this is a traumatic or a non-traumatic, and assign the appropriate codes. So neurological involvement, that means this radiculopathy, myelopathy, cauda involvement, that is neurological involvement, and documentation specificity. So while coding spinal condition, uh, these all are mentioned in a, what our IP document. Okay. Otherwise, we have to query to the physician for the specificity or underlying pathology or episode of care, like whatever it is. So the first point, identify the anatomical level, that we have already discussed, at what level the spinal injury happened: cervical, thoracic, lumbar, sacral. These codes are used when the injury is confirmed and associated with neurological deficits. Then the second, use the most specific code available. The documentation must specify exact spinal level, which level the injury happened. That level should must there in the IP document. Okay, whether the injury is complete or incomplete, associated deficits should be documented. The cause of injury also should be documented. Then follow general ICD term, CM injury coding rules. That means acute injuries, we have to code the acute injury first, and with the seventh character A, D, and S. Okay. Then differentiate spinal cord injury versus vertebral injury, that we already discussed. A vertebral fracture does not automatically mean spinal cord injury. Both may be coded if documented. Then include external cause code when applicable, mainly for traumatic injuries. While leading traumatic injuries, we have to assign this external code as a secondary diagnosis, especially for traumatic injury. So otherwise, it will end up in rejection. So these are the ICD categories for spinal conditions. Mainly M series and G series codes are used for coding spinal conditions. So spinal stenosis M48.0, intervertebral disc disorder M51 series, dorsalgia M54 series, spondylosis with myelopathy or radiculopathy M47 series. S series mainly for traumatic injuries or current injury. Okay, S series, traumatic spinal cord injuries. Then cervical region code range comes as 14, injury of cervical spinal cord, thoracic S24, lumbosacral S34. Okay, then one ICT coding CM coding guideline we have is coding spinal procedures or stimulation devices requires separate procedure coding and by specific rules. This is the one. Understanding the underlying pathology helps ensure correct classification. That means when a when an admission or encounter is for a procedure aimed at treating the underlying condition, a code for the underlying condition should be assigned as the principal diagnosis. That means if a patient admitted for what spinal fusion, we have to assign the condition that will leads to spinal fusion. Okay, so we have to assign the underlying condition. That means if spinal fusion is performed for vertebral fracture, we have to assign the vertebral fracture as the principal diagnosis. Okay, likewise, when a patient admitted for pain control or pain management, if a patient has a intervertebral disc displacement also, the underlying cause of the pain should be reported as an additional diagnosis if known. That means if when a pain control or pain management is the reason for admission or encounter, that means for chronic pain, usually a physician will perform injection of steroid or epidural injection or facet joint injection, like injection of steroid into the spinal canal or injection of anesthetic into the spinal canal. That physicians will perform these injection procedures usually to treat the pain or to manage the pain in the spinal region. But in that scenario, we have to identify the cause of the pain, cause of the underlying cause of the what underlying cause of the pain should be reported as the additional diagnosis. In brief, okay. So in brief, this while coding, this spinal conditions, we have to check for the specificity. Highest level. We have to check for at what level this condition affected, then the combination code available or not, then sequencing based on the reason for encounter, and avoid code for the most specific codes. Assign most to the most specific codes. Don't go for unspecified codes. Next comes to procedures. So major categories of spinal cord procedures. So in this session, we are going to see the procedures that we perform on the spinal cord or spinal column and also its coding aspects. Okay. So the first procedure is lumbar diagnostic procedure. So under diagnostic procedure, this lumbar puncture, myelography, evoked potential also come under, all are come under diagnostic procedure. What is lumbar puncture? Lumbar puncture, which means diagnostic or therapeutic CSF removal. So CSF means cerebrospinal fluid, where we can see this cerebrospinal fluid within the spinal canal or spinal cord. We can see this is cerebrospinal fluid. So this lumbar puncture, which means here, this is lumbar puncture. This which means a physician drains what CSF from the L3 to L4 region for either diagnostic purpose or therapeutic purpose. Physician drains the CSF fluid from the lumbar region mainly for diagnostic purpose or therapeutic purpose. Diagnostic purpose, which means to diagnose a condition. like in meningitis. So if a patient admitted with headache and neck stiffness, physicians clinically suspect this as meningitis, but uh, con- uh, to diagnose the condition, we require lumbar puncture of CSF fluid, because this physician drains the CSF fluid, and this CSF fluid will send for CSF culture, and we have to check CSF protein, I mean CSF protein and CSF cell count. So this will helps to identify whether the patient developed meningitis or not, because in case of meningitis, the CSF protein count will be more. Okay. Sometimes this culture may be positive. CSF culture may be positive. So that is the for diagnostic purpose. This is the example for diagnostic removal of CSF fluid. So then comes to therapeutic. Therapeutic means as a treatment, the physician will perform CSF drainage, like in CSF leakage or therapeutic drug administration. They will perform lumbar puncture. So this is the this is all about lumbar puncture. So then comes myelography. So what is myelography? It is a study. Actually, it is a contrast imaging of the spinal cord. That means a physician uh, inject radio contrast material into the spinal canal to diagnose a particular conditions, like a tumor or growth. For that, we usually perform myelography. Okay. So evoked potentials that are also intraoperative neurophysiologic monitoring. So physicians will create electrode signals to the spine for monitoring. So this is the diagnostic. These are the procedures that come under diagnostic studies. So lumbar puncture, myelography, evoked potential. So we have one CPT assistant for myelogram. That is, if a patient admitted for myelography, and in the same encounter, the physician will perform cervical myelogram and lumbar myelogram. We have to report the CPT code once only. Okay, that is the CPT code for once per encounter, once only. That is the This is that CPT assistant. That is the code for CPT code for myelography is 62284. So if a patient had cervical and lumbar myelogram with the injection of contrast by lumbar approach, what would the correct reporting to be? Code 62284 would only be reported once per encounter. If a patient had cervical and lumbar myelogram with the injection of contrast, then only one injection code would be reported. So coders must check the CPT assistance also while coding spinal procedures. Okay. So this you have to keep it in mind. Then comes decompression procedures. What are decompression procedures? Decompression procedures are mainly done to uh, decompress the spinal cord or spinal nerve roots. Okay. So mainly it is caused by intervertebral disc disorder, which may lead to compression of nerve root and spinal cord. Spinal stenosis will lead to spinal cord compression. So for these type of diagnosis, physician will suggest these decompression procedures like laminectomy, laminotomy, foraminotomy, discectomy, etc. From the word itself, we can identify what are the procedures. So laminectomy, which means removal of lamina. We already this is the diagrammatic representation. So this is the spinous process, this transverse process, this side these side projections are transverse process. In between this process, there is a lamina. So what will physician do? This laminectomy means the physician will remove the lamina because this is the what compressed. This here, this code is compressed. So physician will remove the lamina. So it will helps in the decompression of the code. Okay, understand? It will helps in the decompression of the code. So laminotomy, it is a partial removal of the lamina. Then foraminotomy, which means this space now in bit this through this foramen or through this space, uh, this nerve root exit. Here also space is there through which nerve root exit. So physician in the foraminotomy, the physician will widen the nerve root exit. So it will helps in decompressing the spinal nerve root. Okay, so this sometimes this enlargement of disc will cause prolapsed disc or herniated disc. It will cause this spinal nerve root to compress. So for that, physician will perform what? Foraminotomy, either foraminotomy or laminectomy or laminotomy or discectomy. So discectomy, which means removal of prolapsed or extruded disc from the intervertebral disc. Prolapsed disc, removal of prolapsed disc. Okay, that is discectomy. So these terms we have to be careful. Laminectomy, laminotomy, foraminotomy, discectomy. These are the decompression. These are the main decompression procedures that the physicians will perform during the compression of spinal cord and spinal nerve root. Okay. Here it is. This herniated disc will cause what? Compression on the spinal nerve. So physician will perform discectomy. Okay. It will decompress the spinal nerve root. So the CPT code that for laminectomy, the CPT code that ranges from starts from 63 series. Okay, for each level they have CPT codes. So cervical laminectomy or laminotomy 630012 to 63003. Thoracic we have CPT codes 6305 to 12. Then lumbar 15 to 17. Laminotomy with the discectomy, we have a series of codes, and re-exploration laminotomy or laminectomy. What is re-exploration laminotomy or laminectomy? In some scenario, if a patient admitted for suppose the patient admitted for the decompression procedure, laminectomy, and in the same encounter, if a physician perform a second laminotomy procedure for some complications, we will code this re-exploration laminotomy additionally for that session for that operative session. Okay, so read the documents carefully while coding spinal surgeries. So laminectomy or laminotomy series ranges from 63001 to 63004. Then comes foraminotomy. Foraminotomy or nerve root decompression. That ranges from 63045 to 48. So cervical, thoracic, lumbar foraminotomy. This is the primary code 63045. It is the primary code, and we have additional code also for reporting additional segments. That means if foraminotomy performed at L1, L2 and L3, L4 level, this L1, L2 is one interspace and L3, L4 is the second interspace. If a physician performs foraminotomy on both levels or both segments. For first level, we have to code the primary CPT, and for the additional levels, we have to code the add-on CPT. Okay. Then spinal canal decompression for stenosis. So we have 63047 for lumbar laminectomy for stenosis. Each additional level, we have to report 48. So for additional levels, the coders must read the document or operative note and assign the correct CPT code for the additional levels also. Okay. Next come repair and reconstruction. Repair and reconstruction means the first dural repair. Dural repair, which means dura matter. We already discussed about the dura matter. So the repair of dura matter is that is for CSF leak repair. We have CPT codes, and it fixes tears in the dura matter, the membrane around the spinal cord, often occurring during surgery or from injury, to stop cerebrospinal fluid leaks. So dural repair is mainly for cerebro CSF leaks. So to fix the CSF leak. So we have CPT codes for that. Then spinal cord untethering. What is spinal cord untethering? That means it frees the spinal cord. This procedure is to freeze the spinal cord from abnormal attachments like scar tissues or thickened fibrous bands. Sometimes this phylum terminale, that is the end portion of this spinal cord that attaches to the coccyx, this portion, these fibrous bands or what adhesions may occur to sometimes this phylum terminale become thickened due to what due to the adhesions of these adhesions or scar tissues. So this will restrict the movement of the spinal cord. So to untether the spinal cord, to untether the tethered spinal cord, the physician will perform spinal cord untethering. Okay. We will have CPT code for this also. Then comes repair of myelomeningocele. This is mainly for spina bifida correction, repair of myelomeningocele. So myelomeningocele repair corrects this severe form of spina bifida by surgically closing the spinal defect, typically done either prenatally or postnatally. I mean, uterine surgery may perform, either intrauterine surgery may perform or after birth to protect the neural tissue. So repair and reconstruction involves dural repair, that is the repair of dura mater, then spinal cord untethering, which means to repair the tethered spinal cord. Okay. Then repair of myelomeningocele, that is particularly for to repair or to correct the spina bifida condition. So these are the CPT codes for repair and reconstruction procedure. So 63707, repair of dural or CSF leak without laminectomy and with laminectomy. So it may perform either with laminectomy or without laminectomy. So coders must check for the coders must check the documentation thoroughly. Okay. Then codes for spinal cord untethering. What are the codes? 63200, 205, 210. Okay. Then comes spinal cord tumor procedures. Of course, we all know that what is a tumor, or it may be cancerous or benign or metastasis. So the spinal cord tumor procedures, mainly excision procedures, are performed for what? Spinal cord tumors. Excision procedures. So excision of intradural tumor, excision of extradural tumor, and biopsy of spinal cord lesion. All these procedures may perform for what? Spinal cord tumors. What is intradural tumor? what is the difference between extradural tumor and intradural tumor? Extradural tumor means outside the dura mater. We all know that spinal cord has a protective covering, and the outermost covering is called dura mater. So outside the dura, but in between the spinal canal, that is a epidural space. So extradural tumor is outside the dura. So dural matter. So that tumor that uh, if patient develop tumor outside the uh, dura or dura mater, it is called extradural tumor. If the tumor is located inside the dura, that is this one, inside the cord, that is intradural, intramedullary. I mean, intradural, two types of intradural tumors are there: intradural intramedullary and intradural extramedullary. That means this yellow colored, this structure is a spinal cord. So this intradural intramedullary, that means within the tumor that grows within the spinal cord. Intradural extramedullary means outside the spinal cord, but in between the meninges. That is intradural extramedullary. So check for whether it is intradural or extradural and assign the appropriate CPT code. So intradural tumor is a growth that develops inside the dura mater. These tumors can compress the spinal cord or nerve root. Types of intradural, extramedullary, and intradural, intramedullary. Extramedullary tumor is the growth that develop outside the spinal cord itself, but still within or around the spinal canal. Types of extramedullary tumors are intradural extramedullary tumor and extradural tumors. Common types of extramedullary tumors are schwannoma, meningioma, metastatic lesions. So this extramedullary means outside the dura but within the spinal canal, in between the dura and the spinal canal. Okay, that is extramedullary. Intramedullary means within the dura. So these are the CPT codes for extradural spinal tumor excision, intradural and intramedullary spinal cord tumor excision. Based on the level that affected, we have to assign the correct CPT codes. Next comes spinal cord stimulator procedures. These spinal cord stimulator procedure or SCS procedure that is mainly used to treat chronic pain management. Because in this procedure, two components are the trial lead and one pulse generator is there. These two is implanted into the human body to treat the chronic pain. So in this, the pulse generator will evoke electrode signals, and this signals will helps in treating the pain. Okay, this is SCS procedures. So we have codes for SES codes for trial leads, permanent implants, pulse generator, revision and removal. Revision and removal, which means revision means once this SES is implanted into the human body and again the patient admitted for the revision, we have to assign the revision. And removal means either the pulse generator or lead may be removed from the body. So we at that time we have to assign removal of SES. Okay, then comes injection and pain management procedure. This is the most common procedure that that we can encounter with. So this is mainly for injection and pain management procedures. These are not in the code but coded as spinal procedures. Actually, these are epidural steroid injection procedures. We can categorize into epidural steroid injection, facet joint injection, nerve root blocks. This is the diagrammatic representation of the epidural steroid injection. So this is the epidural space. So usually steroid or anesthetic may be injected into the epidural space to treat the pain or to treat the inflamed nerve root. Okay. Like to the facet joint, if a physician injects anesthetic or steroid, we have to assign the CPT codes for facet joint injections. So thoroughly read the documents whether this injection if patient is admitted for a epidural or whether it is for facet joint, you have to thoroughly read it and report the appropriate code. We have so many codes for epidural steroid injection, facet joint, medial branch block, peripheral nerve block, sacroiliac joint, and radiofrequency ablation. These injection procedures, usually in these procedures, we inject anesthetic or steroid, whereas in radiofrequency ablation, it is for destruction. Neurolytic agents are used in radiofrequency ablation. So check for the specificity and the anatomical level and code appropriate codes. So we have some guidelines for spinal injection procedures. So injection of contrast during these injection procedures may be performed either under with the help of ultrasonic guidance or fluoroscopic guidance, or with the help of guidance or without imaging guidance, physician may perform injection procedures. So, but these imaging guidance, CPT codes for imaging guidance are included in the injection procedure code. So no need to report separately. Okay. Then mostly the injection procedure codes are unilateral codes. So if a physician performs these injection procedures bilaterally, then we have to assign or append the modifier 50 bilateral. Okay. And the next guideline, if injections are performed at different spinal level, the spinal injection codes should be reported for each level of the involved spinal region. That means if physician may perform injection on L1 and L2, then L3, L4, then we have to assign the CPT codes for both L1 and L1, L2 space and L3, L4 space. Okay, so both levels we have to report CPT code for both levels. Next comes CSF shunt placement, shunt revision, and CSF drainage catheter. That is, we already discussed 62272. That is for therapeutic lumbar puncture. And these are the codes for CSF shunt placement 62223 and 62230. Then fusion and stabilization. This is the more complex procedure, and this is a more high cost procedure also. And what is a fusion and stabilization? What is a fusion? A spinal fusion. Spinal fusion, it is a fusion of, or it connects two or more vertebrae, so they heal into a single bone. It is fusion of two vertebrae is called spinal fusion. That means if a patient admitted with intervertebral herniated disc at L1 and L2, that means the disc in between the L1 and L2 become herniated or prolapsed. The physicians will do the discectomy. Physician will remove the disc in between L1 and L2, and they will place a graft in between these vertebrae, and with the help of instrumentation, they will do spinal instrumentation. That means they will fix these bonds by using rods or cages or screws, pedicle screws. So this is what spinal fusion is. Spinal fusion, which means the fusion of two bonds. So usually the physicians will remove the disc in between the based on the Diagnosis. So if a patient admitted for a herniated disc or prolapsed disc, the physician will remove the disc in between the affected vertebrae and will replace it with bone graft, and that is the physician will place the bone graft in between the vertebrae, and physician will fuse these vertebrae by spinal instrumentation by using pedicle screws, cages, or rods. So while coding spinal fusion, we have to be careful about the what uh, this is how many screws used, or how many plates used, or how many rods used. We have to be careful. Then the type of graft used, that is bone graft, a type of bone graft, that is allograft or autograft. Allograft, which means allograft means that is not self, that is harvested from other other person. Okay, that is allograft. Then or synthetic, or maybe it may be synthetic also. Then example TBM putty that we used usually commonly we used in spinal fusion procedures. Then autograft, which means this through laminectomy we have to means a physician may harvest patients on graft, that is autograft. So we have to check for whether the graft harvested is autograft or allograft. We have to check. So this is actually the spinal fusion procedure, and why it is done, that I have already told. For herniated disc and common reasons, other common reasons include degenerative disc disease, spinal instability, severe scoliosis or kyphosis. To correct lordosis or scoliosis or kyphosis, physician may what may perform this arthrodesis or spinal fusion. To treat fractures, then chronic back pain linked to movement between vertebrae, then spinal stenosis when decompression alone isn't enough. So this spinal fusion is also called as spondylodesis or spondylosynthesis. Desis means fusion. Okay. The goal of the spinal fusion surgery is to correct the curvature, stabilize the spine, and for spinal stenosis, spinal fracture and injuries, and to treat the pain. So uh, be careful while coding spinal fusion surgery. Then the main techniques that used in spinal fusion are based on the approach. We have to select the technique. That means if spinal fusion surgery performed by in a posterior means if a patient lie in a prone position, and the physician may perform the surgery, that we have to uh, that is posterior approach. So we have to select the CPT code for posterior lumbar interbody fusion. So approaches based on surgical direction. That is, if patient lie in a prone position, that is posterior. If a patient lie in a supine position, that is anterior. So we have to read the document or operative note thoroughly. So approaches based on surgical direction. That means anterior lumbar interbody fusion is there. Posterior lumbar interbody fusion is there. Anterior means from the anterior side or front side. Posterior means from the back side or posterior side. Then transforaminal. Under posterior lumbar interbody fusion, this transforaminal lumbar interbody fusion and lateral lumbar interbody fusion will come. This lateral means side approach. Then anterior cervical discectomy and fusion, that is cervical, and posterior lateral fusion. Posterior lateral, which means the approach is through posterior, but the bone graft fixation is by lateral. So correct the appropriate technique code. Then how surgeon choose a technique? Based on the location of the problem, which level affected, then cause of the instability or pain, what is the underlying condition. Based on that, need for nerve decompression and patient anatomy and overall health. Then these are the CPT codes for spinal fusion surgeries. We have separate codes for cervical, lumbar, then interbody fusion. And so mainly this spinal fusion is, we can classify the spinal fusion into interbody fusion and posterior or posterolateral fusion. Okay, anterior fusion is there, posterior fusion is there. Within the posterior fusion, we can uh, divide it into interbody fusion and posterior or posterolateral fusion. Mainly interbody, which means within the name itself, we can identify interbody, which means in between the physician will remove the disc from the in between disc that located in between the vertebrae, in between the vertebral body. That is interbody fusion. Whereas in the posterolateral fusion technique, what physician will do is physicians will remove the disc, but the bone graft is placed laterally along along the side of the transverse process. So, and fix it. That is the posterolateral fusion. So identify what level, so differentiate the coders must check for the approach and technique that used, and assign the appropriate CPT codes. And for each additional levels, we have to assign the CPT code for interbody fusion and posterolateral spinal fusion. Then CPT coding guidelines for spinal fusion. We already discussed, understand the anatomical regions, which level affected. Each region is coded separately. For example, lumbar fusion and cervical fusion require two separate primary codes. If within the same encounter, if a physician performs a lumbar fusion and a cervical fusion, assign the CPT codes for both cervical and lumbar separately. Then identify the decompression versus fusion. Decompression versus fusion are coded separately if it is performed on the different anatomical level. That means if fusion performed on L1, L2 and decompression performed on L4, L5, we can code both separately. Otherwise, it is included in the fusion CPT code for fusion. No need to code. Instrumentation codes are add-on codes. So we have CPT codes for instrumentation, spinal instrumentation, because spinal fusion surgery, it has 3 steps. No, spinal fusion surgery, that is removal of the disc, then placement of the graft, then instrumentation. So for this, we have to assign the CPT codes for both the graft and the instrumentation also. So these instrumentation codes are add-on codes. So based on the approach code, assign the appropriate code. Based on posterior segmental instrumentation, anterior instrumentation, interbody devices. Based on that, we have to assign the appropriate codes. Then code by approach, anterior versus posterior, prone position or supine position. Based on that, you have to code the primary code. Then bone grafting codes. So we have separate CPT codes for autograft and allograft, and for combo code also available. So based on that, we have to assign the correct CPT code for bone graft also. Then what is the difference between levels versus segment? If the documentation is like L1 to L3, it means a level, and L1, which is a segment, L2 alone, it is a segment, L1 to L2, which means a level. Then comes endoscopic versus open procedures. So endoscopic spine procedures have distinct CPT codes. That means if a physician perform discectomy endoscopically, we have a separate code, and for open discectomy, we have a separate code. So identify the whether it is endoscopic or open procedure. Then comes exploration, removal, or revision of hardware. If a patient readmitted for the removal of cage or removal of rods due to some complications, we have a separate CPT code for removal or revision of hardware. So assign the appropriate CPT code. Then bundling and NCCI edits. Bundling and NCCI edits, which means usually this discectomy is included in the spinal fusion CPTs. So they are not separately reportable. Discectomy CPT code for discectomy is not separately reportable along with this fusion CPTs. Identify whether it is identify and code, assign the appropriate code. Otherwise, it will end up in rejection. Then modify reuse. Then appropriate use of 59, 51, and 22. Usually in Abu Dhabi coding, we are not usually using modifier in inpatient coding. Then coding guidelines for spinal fusion. That is documentation requirements. That in the OT note or IP documents, it should clearly mention the approach, the levels and segments, cervical lumbar, which level affected, purpose of decompression, type of instrumentation, whether it is what type of instrumentation used, rod, screws, whatever it is used, type of graft, allo, auto, or both. Then morselized or structural graft, that what type of graft they used, that have to be documented, whether hardware was removed, medical necessity for each component. Then next, so this is all about the procedures that usually perform on spinal column or spinal cord, and the CPT codes and the CPT guidelines that we have to follow. So usually diagnostic procedures, mainly lumbar procedure, myelography, then other procedures, decompression procedures, laminotomy, laminectomy, foraminotomy, usually for decompression of spinal nerve and spinal cord. Nerve means nerve roots and spinal cord. Then repair and reconstruction procedures, mainly for CSF leak. Physicians will perform this dura repair. So then spinal fusion. Spinal fusion is the most complex procedure. So we have to be careful while coding. So next, common insurance denial scenarios in spinal procedure coding. So this we have to be more careful while coding spinal procedures, because inappropriate coding or these unspecified codes will lead to rejections. This insurance deny with this if a medical necessity is not there, insurance will deny the our revision request. So we have to be careful. So below are the most frequent categories of denials. First one, medical necessity denials, then coding and billing errors, then bundling and NCCI edit denials, then authorization and policy denials that is not related to coding, prior authorization that is related to prior approval team will take prior approval, no, that is related to prior approval. Then diagnosis to procedure mismatch, implant and device related denials, modifier misuse denials, place of service, and complete or missing documentation. So what is medical necessity denials? Medical necessity denials occur when the payer determines that the clinical documentation does not justify the spinal surgery performed. That means insufficient documentation of the conservative treatment. This spinal physician will decide this surgery after the failure of this conservative treatment. So that documentation should be there in the IP documents. So insufficient documentation of the conservative treatment will lead to rejection, or lack of correlation between imaging and symptoms. That means if the patient admitted for spinal surgery with a diagnosis of what loss of lumbar lordosis, but in the MRI this loss of lumbar lordosis is missing, then insurance will deny, payer will deny the revision request. Okay. That is the lack of correlation between imaging and symptoms. Non-covered indications for spinal fusion. That means many plans deny fusion for degenerative disc disease without instability. So this instability should be there in the document. Failure to document neurological deficits like weakness, loss of reflexes, or sensory changes. So these all come under medical necessity denials. So there should be sufficient documentation for coding spinal surgery. Otherwise, insurance will deny. Then coding and billing errors. That is, this is the coding part. So coders must check the NCCI edits and bundled codes and unbundled codes and code appropriately. Otherwise, rejection will occur. No, incorrect CPT code selection using laminectomy when documentation supports laminotomy. So if as per OT note, if laminotomy is performed and the coder assigned the CPT code for laminectomy, then surely the insurance will reject the revision or they will not pay for the procedure. Unbundling of inclusive services. That means decompression and fusion components often bundle under NCCI edit. Many spinal procedures include foraminotomy, discectomy, laminectomy. That means in fusion at same level, this discectomy and laminotomy is included. So no need to report separately. But if coder assigned the CPT, it will mark as an error. And okay. So billing them separately when they are part of the primary procedure triggers bundling denials under NCCI edits. So missing or incorrect modifiers, wrong number of spinal levels built. If a physician performed a procedure on 2 levels only and coder coded for 3 levels, then what it will end up in rejection. So coder should aware of or coder should take care of this coding and appropriate coding. Then bundling and NCCI edit denials. That is, we already discussed that bundled codes do not report separately for the same level. So we have to check before while coding. Next comes authorization and policy denials. Authorization and policy denials are some of the most frustrating because they occur before coding even matters. Because suppose if patient, if prior approval taken for L4, L5 level, but surgery performed on L1 and 2 level, then there is a discrepancy between the levels. So this will end up in rejection. So diagnosis to procedure mismatch. That means if these denials occur when ICD-10 diagnosis codes do not adequately support the CPT procedure codes built. That means, for example, coding a fusion without a diagnosis of instability, spondylolisthesis, or deformity, or severe stenosis. Without this, the pair argues the surgery was not medically necessary and they will not pay. Like, so if we code the diagnosis, the procedure and diagnosis should match. Okay. Then implant and device related denials. That due to the lack of invoice copy, which means the regarding the what implants or rods, screws. We will use rods, screws, or cages in spinal fusion surgery now. So the missing invoice copy will lead to denials. So take care of that. Then modifier misuse denials. Usually we are not using the modifier in UAE coding. Then place of service or facility denials. That means some procedures require inpatient admission. Some procedure require only outpatient admission. So it will code as ambulatory service. Ambulatory surgical center will claim that one. So if outpatient surgery, it is patient admitted as an inpatient, but within the encounter, the surgery performed is a outpatient, then means a minor surgery, then sometimes based on the place of service, the insurance will deny it. Then incomplete or missing documentation. Of course, the specificity should be there, and appropriate what levels treated, laterality, specific decompression techniques, implant details, everything should be there. Otherwise, sometimes rejection may happen. So this is about the denials. So to prevent or to overcome these denials, there must be proper documentation. So we have to be take care. So while coding, if anything missing in the documentation, we have to query the physician and update the documents accordingly. So it will helps in preventing the rejection. Okay, so that's all about the today's session. So thank you for your patience and thank you for your attention. So if you have any doubts or queries, please ask. Thank you, sir. If no, if any doubts or queries, they can ask. Thank you, sir.